Yeah, I had a quick question. It says you're in a practice session. Okay,
Yeah, it should have just
it's
gone
changed now.
away.
Okay.
Okay, great.
That's good.
Well, for folks who are joining, welcome to our webinar in the 21st Century Research Agenda series. We will get started in just a few minutes. Okay, as folks are filtering into the room, we'll go ahead and get started today with our presentation on behind the scenes in home visitation research, RCT challenges in community settings. It is part of our 21st Century Agenda webinar series. We do have one more webinar coming up in this series as well, so we hope you'll join us for that on November 7th. And also catch the recordings of the past sessions available on our YouTube channel. We'll share the link for that. If you have questions for our speakers today, we just ask that you share those in the chat at the end of, so that we can pull them up at the end of the call for some Q&A. I'd like to take a moment to introduce the folks on the call today and our speakers. So I'm joined by Dr. Craig Winston LaCroix. He is the Communist Professor of Social Work at Arizona State University. Allison Kemner, she's the Senior Vice President and Chief Research Officer at Parents as Teachers National Center. And I'm also joined by my partners from the American Academy of Social Work and Social Welfare, including Mary McKay, who is the former president of the board at the Academy and vice provost of interdisciplinary initiatives at Washington University in St. Louis, and Nicholas Asher and Sanjam Dutt, who are program coordinators with the Academy as well. We'll also be joined today by Susan Stone, the interim dean for Berkeley Social Welfare, as well as she's also the Catherine Mary and Eileen Claire Hodo Professor of Social Services in Public Education at the School of Social Welfare, and she will be moderating our Q&A later on in this panel discussion. So thanks everyone for being here. I am Stephanie Anderson. I'm the manager of the Clark Fox Policy Institute at the Brown School at Washington University in St. Louis, and I'm happy to be joining you all today. I'm going to hand it over to Nicholas to share a little bit more about the 21st Century Agenda.
Thank you so much, Stephanie. Since May of 2019, a diverse group of researchers, DEI experts, people with lived experience within the child welfare system, and policy experts have worked together to identify research gaps to enhance the development of the 21st century approach to a child and family well-being system. What began as a partnership between Casey Family Programs, the Annie E. Casey Foundation, and the William T. Grant Foundation has evolved into a wider coalition of academic, national, and philanthropic organizations, bolstered by extensive participation from individuals with lived experience from the child welfare system. We believe that new studies should address the most critical issues facing the field so that the research findings can be used to support innovative policy, practice, and changes in funding. Currently, the Research Agenda Coalition is encouraging federal, state, and local foundations to address the high priority research gaps that we are actively promoting conversations in a few key topic areas. And these topic areas include helping the research community see study participants as partners in the research, as part of prioritizing a commitment to social justice. And we believe that stakeholder involvement will help researchers focus on the most critical issues, especially if this activity is funded adequately. Participation by community leaders and people with lived expertise in the development of the research study lays the groundwork for the type of collaborations required to conduct the research ethically and effectively. To that end, some cultural experts and people with lived expertise on our team have just produced a DEI tool to help enhance program planning and research study development. These collaborative research approaches can help ensure that the research meets the needs of not only the researchers, but the children, families, and communities that are being served. So we are trying to improve how research is done while we help get more studies funded in the high priority areas. and I'll drop the 5-page initiative overview that was emailed to you earlier today in the chat. And our next upcoming webinar on November 7th will actually be exploring the DEI tool further. And I'll bounce to you, Mary.
Well, thank you, Nicholas. And so my words of welcome on behalf of the American Academy of Social Work and Social Welfare. Welcome those of you that are live here on this webinar. We also know that many of you after the fact will watch us on YouTube. And so thank you in advance for spending the time. If you've missed any in the series, we've held a number of webinars previously. Those are archived on the Academy's website, and we encourage you to not miss that content. What's really important about today's conversation and the webinar series in general is it reflects the commitment of the foundations of the Academy to think about not only research that truly matters, in this case, in the area of children, families, communities, but also how we do that research. And so today you will hear about a partnership that really matters. And we hope that this will generate some questions, some best practices, some lessons learned that really inform what all of you who are our audience, the work that you're engaged in. So with that, I really want to thank, in particular, my co-board member, Susan Stone. She will be with you in the entirety and facilitating the question and answer. Craig, thank you for being an outstanding fellow. Allison, we look forward to really hearing your contributions from parents as partners. It took a lot of people to get us here. And so both Stephanie to you and Nicholas and Sanjam, thank you for organizing this. And with that, I'll drop off and leave you to your important work. I look forward to reviewing the webinar in its entirety. Thank you.
Thanks, Mary, so much. So we'll hand it over to Dr. LaCroix and Allison to share their presentation.
Okay, thank you. I appreciate the introduction. All right, here we go. Let me get this started for us. All right, can everybody see that? Are we good?
Looks
Yes.
good.
Okay. Thank you, Allison. Okay, so today we're going to talk about behind the scenes in home visitation research. And our interest is not just sharing the results of a study, but sharing more in depth with you about some of the issues in trying to do this research, some of the real challenges that we faced, and really helping us all kind of reflect on where we're at in terms of this opportunity and challenge for doing research. So I'm Craig LaCroix, and as was mentioned, I'm with Arizona State University, but this work I've been doing through my program evaluation company, LaCroix & Milligan Associates, located in Tucson, Arizona. And Allison, you want to take this slide?
Sure. Hi, I'm Allison Kemner. I'm the Senior Vice President, Chief Research Officer at Parents as Teachers National Center. We are headquartered in St. Louis, Missouri, but our evidence-based parent support and home visiting model operates worldwide. And we support families with young children, prenatal to kindergarten. And you'll hear more about our footprint later.
Thank you, Allison. Okay, we thought it would be good to do this presentation in 3 parts. So we're going to talk about an overview of the program and a little bit about our randomized controlled trial. And then we're going to pause and have the program perspective from Allison, a research perspective from myself. Then we're talking about key considerations in community settings, again, with Allison presenting the program, myself presenting the research, and then finally dig very deep into the challenges and solutions and talk about the program perspective and the research perspective. So we have a tremendous amount to say about some of our experiences, and hopefully people will be interested and we can create a learning environment from our experiences. Okay, Allison, you want to start with the overview of the program?
Yeah. So Parents as Teachers is an evidence-based home visiting model, and we're celebrating our 40th year anniversary this year, which is really exciting. We are backed by 40 years of research, which is going to be an important indicator that we'll talk about later. And the program delivery is occurring in 49 states and 6 other countries. So I'm going to give a little bit more of an overview, and I'm going to talk about like why we invested in this randomized control trial that we conducted with Dr. Craig LaCroix and his team, and talk about really the importance of program and research integration. So on the next slide, you can see a little bit of a program overview. I mentioned that we operate in 49 states and 6 countries. The components of our home visiting model is really working with families and meeting them where they are, oftentimes in their home, and providing home visits. We call them personal visits because they don't have to take place in the home. They could also be conducted virtually. You can meet them at a park, a playground, and it's really supporting that family on 3 areas of emphasis. So development-centered parenting, which is really looking at the intersection between child development and parenting behaviors and how those kind of 2 coexist together. Parent-child interaction, creating opportunities for families and everyday living activities to have meaningful interactions together. And family well-being. So knowing that there's many basic essentials and stressors families are experiencing each day. And so the professionals are trained to support those families in navigating all of that. Our trained workforce also works with families on doing child and caregiver screenings as another part of our component, referring to community resources. And we, as part of our model too, we have group meetings. And this is a place where families come together to create social support, social interactions, and really an important part of the work, especially today in the isolated nature that we really have. The outcomes we focus on, you'll hear more about within this study, but we're looking at the parent, we're looking at the child, we're looking at the whole family. And so you'll hear more about some of the outcomes that were investigated in this study. So this is a map of our annual REACH data. We last year trained and certified 8,555 home visitors and professionals that partnered with 222,000 children and 186,000 families and delivered almost 1.8 million visits, which is really quite a lot of services offered. And this just kind of gives you some of the other service delivery number to help you understand the scale at which our program operates. Today, what you'll hear more about is really zooming in on this randomized control trial, and I'll talk a little bit about why we kind of invested in this randomized control trial. And you'll hear a little bit around the design and some of the challenges and complications here. So and I don't know, Craig, if you wanted to take this slide here and talk a little bit more about the program, and then I'll get into some of the why in a minute.
Sure, it sounds good. So just in terms of the intervention, I mean, a lot of people are familiar with parents as teachers. In fact, before this call, several parents were talking about their own experience with parents as teachers. So it is just really interesting to think about the need and the societal response to providing the support that parents need. It's such a huge deal. But the parents as teachers intervention in this study, it was normal PAT services. And of course, that also included participation in data collection. So we collected data at baseline 6, 12, and 18 months. And that was how we set up the overall study. It included, like Allison had mentioned, the traditional components of the personal visits, the connections, the screenings, that kind of stuff. For the control group, what we did is that the participants that were interested in parents as teachers went to a centralized site. They were described the study, and then if they agreed to participate in the study, they were randomized to either the PAT intervention or the control group. The control group, of course, included the data collection, baseline 6 months, 12 and 18-month data. We kept track of them because retention, we'll talk about that later, was important. So we sent them birthday cards and other strategies for keeping them engaged as much as possible. They did get the developmental assessments that were made available, and they had visits. And so the research staff visited them, asked them, talked to them about their family. And then all the families were given community resources. So they were encouraged to use community resources as needed.
So a little bit about why we got into this study. So investing in research and learning is obviously a critical part of any model or program services. And over the last 10 years, we've been really invested more in thinking about quality improvement. However, there are these evidence-based clearinghouses that review research on home visiting models and other social service programs. And evidence is important to your rating and ultimately the funding that goes to states and communities to do the work in communities. And while I mentioned earlier, we've had 40 years of research and we've had prior randomized control trials, questions started to emerge around the evidence of parents as teachers, as we hadn't had a more recent randomized control trial done in the United States. There are many other rigorous designs on parents as teachers and other home visiting model, but some of these clearinghouses only look at a very narrow scope. So this really led us to saying, okay, this is something that we need to invest in, even though we have some concerns about this study design, which we'll talk more about as we continue. So through that, we identified a great partner, Craig LaCroix and his team, who had experience doing these trials and had a relationship already with community-based organizations that were implementing parents as teachers in Arizona. And that led us to kind of exploring together what it might look like to set up this design and leverage funding for it. I will say that starting out, Parents as Teachers National Center invested our own dollars in this project because we thought it was critical. So oftentimes funders don't invest in planning that work. And so this was an important investment. And along the way, we've been able to leverage funds, which we can share more about later.
Yeah, and Allison, I have a quick question for you. I'm just curious, how was the decision made from the PAT national group to go forth with this? Is that just like a board of directors, or what was the process? Any information you could share about that would be interesting.
So that's really helpful and a great question, Craig. What we did is we were doing a scan of where we were in the clearinghouses, particularly the one that only looks at randomized control trials. And we were seeing that our evidence, if they put in some sort of timeline standard, might roll off and might not then be included any longer. So we presented some of this to our board of directors, and they said this is an important investment we must make. And if we fund it out of our own operating budget, we will do that to get it started while the team continues to think about opportunities for funding. So it really was looking at the data and where we were in the standing and hearing from states some questions around our evidence and having to continue to justify the narrative that there's much more evidence than what's included in some of these clearinghouses. That really led us to the place.
Great, thank you. Yeah, okay. So just from the research perspective, and this just kind of adds to what Allison was saying, you know, in the research community, it's pretty clear that RCTs are considered the gold standard, right? Due to their ability to provide this robust evidence about an intervention's effectiveness. And this standard is really, this is a very interesting policy consideration. The standard, as you could hear from Allison's description, is promoted by this home visiting evidence of effectiveness website and review, where they regularly evaluate up to 50 home visitation models. And what's kind of interesting is that very few models meet all the standards of evidence put forth by the Home V, as it's called. These rigorous standards include all sorts of things like, you know, not too much differential attrition, no reassignment of treatment and control, no confounding factors, differences in data collection, having to have equivalent baseline variables and controls, all of these things. Despite the desirable qualities of an RCT, this rigor of study presents many complexities and challenges when implemented in a community setting. And I think that's a lot of what we're trying to underscore here today. It's interesting, among the 53 home visiting models that were reviewed by this Home V website from 1979 to 2018, only 24 met the criteria for having at least one high or moderate rated study, including PAT. Specifically, with regard to PAT studies, 100 studies were identified, 30 were reviewed, and only 2 were rated high. So that's 6% of the total studies. on PAT, which raises questions about why so many studies were able to, why so few studies were able to meet the standards required to obtain a high rating. And as Allison pointed out, a lot of these studies were 14 years old. But let me just say that missing from the home V consideration is really the feasibility of conducting these studies. Given the expansion of home visitation, understanding the feasibility, I think, is even more vital today when we try to think about how do we continue to look and mount evidence and still be responsive to the feasibility of some of these demands. Researchers have written a little bit about some of these challenges in RCTs. We know a little bit about, issues around dealing with ethical considerations in the community, or people talk about implementation science and how programs are implemented, recruitment, retention. But I don't think that we've paid quite enough attention to the difficulties. And in some ways, if you consider the home V data, it's kind of interesting that fewer studies have been able to be brought forward as having the evidence that's needed, in spite of the fact that I think there's continuing interest in trying to fund these studies. So that's just, I think, really interesting issue. In terms of our research goals, what we wanted to do when we set out to work with Allison on this is to really do a good job, a better job, if you will, of identifying and capturing the kinds of outcomes that home visitation program models like Parents as Teachers accomplish. We felt like we were in a good position to rethink and identify the best way to capture that outcomes. And we also knew we had to balance the rigor and practicality because we'd done this before. We had some experience with some of the difficulties. Okay. So in terms of just the design study and methodology, again, RCT design, we were going to test the effectiveness of Parents as Teachers on child and caregiver outcomes. Again, another challenge, trying to get data from both children and caregivers or parents. And we also were under pressure to collect data at 6, 12, and 18 months because the HomeV website really emphasizes long-term follow-up. So that's another interesting question for us to think about from a policy point of view. Is it realistic to collect that long-term follow-up data? So families then were randomized, of course, to the treatment or the control group, and they were recruited from the affiliate sites in Arizona. Specifically, we're in Arizona, so we had enough good PAT sites in Arizona to conduct the study here, and that's what we went with. Allison, you can mention this too as soon as I'm done about the blue ribbon sites that we had selected, in particular blue ribbon sites. Now, just to mention one of our first wrinkles was around the randomization. So initially, we did a traditional study where we were randomizing one treatment, one control family. And one of the things that became obvious fairly soon is that these sites were having some difficulty recruiting the parents to be involved. Because if you think about it, like you're basically taking away half of all the potentially interested parents from the program because half of them are being siphoned off into the control group. The program sites, that made them a lot of nervous. Their funding depends on the amount of families that they recruit. And this is, an environment where there are other home visitation programs going on. So, competing for that population of resources to deliver the program, caused a lot of angst among them. So one of the early things that we did is that we shifted our randomization to a 2-1 randomization. So now we're 2 families go into PAT, 1 family goes into the control group. And while some researchers might question this, by and large, it's accepted as a viable randomization strategy that works and still preserves the randomization. And of course, we would continue to test the effectiveness of the randomization by looking at the baseline equivalence. But Allison, can you talk about the blue ribbon sites for a minute?
Yeah. So in this study, when we were looking at conducting it, implementation oftentimes from past research becomes a question. our programs implementing to fidelity, and what are their standards and what does that look like? And so for this study, we selected affiliates that had gone through our endorsement, which is like an accreditation process, which means they've been in operation for 5 years, they've been meeting minimum standards, but they're also operating at best practice. And so they are reviewed thoroughly, so we know that they're implementing with quality. And that was important to us, as there has been some, again, as I mentioned, some past research that suggests quality of what happens in a home visit is a little bit messy and unknown. And so it was important for us that we understood the quality before moving into investing in a randomized control trial.
Thanks. Okay, and so then one of the things that we thought we could bring to this study was a very careful review of the measures. We have looked at a lot of different measures in home visitation. If you look at the HomeV website, you will find over 500 different measures that have been selected to examine the effectiveness of home visitation programs. That's 500. Can you imagine 500? That seems like a lot to me. And I think that tells you maybe something about some of the difficulty in trying to figure out what is the best way to tap into the effectiveness of a home visitation program and measure that. And if you look at the measures on that site, other things reveal themselves that are interesting. Like in one case, one measure was documented as a positive effect for home visitation, and that exact same measure in another study was documented as a negative effect of the home visitation program. So I think it's clear that the whole measurement issue is complicated in home visitation, and one of the more fascinating things to think about in the context of building evidence for a particular program. And people just have a lot of different ideas. Like I've heard a lot of researchers talk about using a lot of different measures. Like it used to be popular that people used emergency room visits as an outcome. Okay, is that a good outcome or a bad outcome? And like, why? Why is that a good measure? And is an emergency room different than urgent care? And is the parent taking the child there because they're really focused on health and wellness, or for some other reason? We don't really know. But yet, people use that as a measure. So I think you can see I have a lot of issues with some of these measures, and other issues with measurement. Sorry, I'm kind of a measurement geek about this. Occur because people select measures often if they just have reliability and validity. So an example would be one that's used a lot is the parenting stress index. Now that's a measure, it's reliable, valid, but it's not designed as an outcome instrument. So it may not be giving us the best opportunity to capture the outcomes that we're trying to achieve. An example of that, one of the items, for example, on that measure is, I was abused as a child. Well, as you can see, when you give that as a pretest, it doesn't change at the post-test or the 6-month or any of the follow-ups. So while not all the items have that problem, having just some of the items, for me, limits the capacity of the measure to capture something that we already know is difficult to capture. So we've got to figure out how to do the best job of capturing that. And that means I think we have to turn to what I call outcome instruments that are uniquely designed to measure those outcomes. So what we focused on are these 4 different domains. Family health and safety. We felt like safety was an important part of the PAT program and something that we could measure effectively and easily. We measured the family risk score. So we used an instrument called the HFPI, the Healthy Families Parenting Inventory. It is an inventory that we developed, again, to uniquely measure outcomes of home visitation and other similar types of programs. All the items on it are changeable items. In this subscale, it was really to look at family risk. Did risk go up or down? And we looked at some caregiver insurance. Then we looked at parenting practices and family functioning. And here we use the Healthy Families Parenting Inventory. It has 9 different subscales, social support, parent-child interaction, things of that nature. But we added a hope index, because we thought that might be important in the context of this study. It hadn't been used in home visitation. We felt like this might be an interesting measure to add to the study. And then to study child development, which is really the most complicated part of this. It's just extremely hard, I think, to get good data on children's progressive development, even though evaluators and policy people like that and we think it's important. We use the Vineland Adaptive Behavior Scales, and we use the frequency of reading to the child, which is a common measure in home visitation. And then we wanted to look at resources and resource utilization. So we looked at how well the families were utilizing different resources. So that's a little bit about our measurement package. I just wanted to share that with you. Okay, Allison, you want to talk about the key considerations for conducting the RCT in a community setting?
Yes, thank you. So first, we really had to think about the engagement of the local agencies that we're implementing. And we spent a year planning this study, which oftentimes isn't factored into thinking about a rigorous trial like this. So I really appreciate that Craig and his team was very intentional and thoughtful and went slow at the beginning for us to kind of be critical about the measures that he just talked about and what we were measuring. There was a logic modeling process during this time with the affiliates or the local implementing organizations to hear about what outcomes they thought were important to measure. And Craig mentioned the item of hope, which was something that was measured. That came up as a result of engagement from the home visitors that were providing the support. They felt like they were really creating a sense of hope in families and wanted to measure that. And so appreciated how Craig and his team were responsive and thought through what might be some measures that could help us investigate that further. So I think the intentional planning process was really critical to gain the buy-in and kind of intentional outcomes and making sure that the outcomes were really thoughtful, investigating what research prior had looked at, but also hearing from the program perspective on that. Throughout the study, there was recruitment challenges and getting agencies on board. We talked with agencies at length around what a randomized controlled trial was. We ourselves have some concerns about this study design, but know it's necessary right now because of the policy implications. So we really talked with them around what it meant, what a control group meant, and that some families were not going to get services, and that's going to be really hard. So there was really very intentional, just making sure they understood what it meant to be a part of this study like this. We also compensated the organizations by waiving their annual affiliation fee. We continued to think about structure with the research team and the community organizations. We met monthly with them throughout to hear about ongoing recruitment issues and challenges, and then quarterly throughout the study to hear about challenges as they have emerged. And Craig even referenced earlier some study design changes that were made, require the 2-to-1 match randomization, so 2 to the intervention group and 1 to the control that we made as a result of early hearing about some recruitment issues. And Craig already referenced to it, it's quite challenging for these programs because they are having funding and funding's requiring them to serve a certain number of families. And so they're supposed to have twice as many families. So we also tried to look at those that had a wait list and considering how they might be better candidates for a study like this, knowing that they had some families in the pipeline that already wanted to receive services. So certainly there's many ethical considerations that come along with a study like this. And it's something philosophically I struggle with, but is needed. And so we're hoping we can help to change the policy implications in the future and have a call to action at the end for you to consider these study designs and more broad criteria. But there's certainly mistrust and ethical concerns arise when there's randomization that occurs and you're denying families services. So there was a resource that was handed out for families that could go get resources on their own. And as being a part of this study too, Craig and his team, the data collectors, I think were a relationship that that family received too, so that there's some support that they're getting inherently by being a part of that study. But we heard that a significant portion of parent educators believed that the RCTs were unfair and that those placed in the control group were really challenging. So we did also give, we called them override cards that were kind of given to help that if they felt a family really needed services, but they were randomized to the control group, they could then get services. So there were some different strategies employed there.
Okay, thank you, Allison. Yeah, so again, just to emphasize the research perspective on the randomization, similar qualms that Allison has about the randomization process. And I just want to say it was simply difficult. In some families, some staff simply don't like the idea of families not getting services, as Allison mentioned. And, I've had this conversation with other researchers, and one in particular who's done several randomized controlled trials. And she said, well, it's not really that critical because more families want the services than they get. So, just because some families don't get the service immediately, we're still serving more families than we can actually serve anyway. I have not been able to make that rationale work. It's a much more emotional issue, and it's an emotional issue because parenting is a big deal, the way people think about parenting. And they always tell this story, Allison's heard it before. This did not occur during this study, but in my first study, I sat around a table and talked to home visitors about the randomization, and a home visitor looked at us and said, "You mean that some families won't get the services?" And tears welled up in her eyes. So it's deeply personal because it just doesn't feel right when families can't get some of these services. So it's a pretty interesting issue. I don't think that you can avoid this issue, and I think it may become a bigger issue in the future. And just to add a little bit of more detail about this in terms of one of the issues that we put in place, which I think was a good idea, is we gave each site a very limited number of bypasses, as Allison mentioned. And so they could, if they felt the family really needed services, they could pull them out of the study. No data was collected. They were not part of the study whatsoever. And that gave them some hope that some of the families that they thought needed it the most could get the services. It was a very limited number, but it helped. It helped the community and the service providers accept the tenets of the study. And I think, it didn't affect the outcome of the study necessarily, although having the families that need it the most probably would lead to a little bit better outcomes, but because it was so limited, it didn't have much of an impact. Okay, data collection. We had conventional data collection protocols, as you might imagine, to try to keep people in the sample as much, including incentives. And that worked reasonably well. At 6 months, our retention rate was 69% at 6 months. I think that's okay. It's not super fantastic. And again, this becomes another policy research issue. What's an acceptable level of attrition? I think that researchers often fail to understand how difficult it is to have retention in a program like this, where it's a prevention program. People are coming to get services from a prevention perspective. And when they feel like they get what they need, they don't want to keep necessarily engaging in the services. And there's lots of good reasons for them to do that. But to do the research in this context makes it difficult. Okay. So again, with the ethical issues, we did face a lot of pressure from the sites. Can I have more bypasses? Can this happen? So we were able to mitigate all of those pressures, but mainly because of what Allison had said. We had been meeting with these program sites, collaboratively using and sharing the data, here's where we are in this study. They really appreciated that. they were always able to raise concerns and issues, and we kept addressing them and dealing with them as much as we could. So that was a really important part of making this study successful. Okay, part 3, challenges and solutions in conducting RCTs in the community settings. So Allison, you want to take it away?
Sure. So program implementation and obviously variability that might exist across sites and community setting is certainly an important factor. And throughout the study, and this is still ongoing, the study is still ongoing and data still being collected. We collected measures of program implementation and fidelity and service deliveries so we could understand how that might influence outcomes. And as I mentioned earlier, the organizations had gone through our endorsement process. So we had more confidence in the quality of services that they were providing. And in the midst of this, there was a COVID-19 pandemic, which certainly influenced a program implementation. And we supported the broader home visiting field, standing up, providing virtual home visiting services based upon some prior pilot work we had done. But many natural disasters exist in communities today and really make it hard to kind of implement these studies under those circumstances. And how do you continue to provide services? So virtual service delivery was an option that occurred, and the data collection team also had to consider and rethink how they collect data during that time of services. Staff buy-in and train. Anything, Craig, you wanted to add there?
No, go ahead.
Staff training and buy-in. So engaging, both the program and research staff in the process. With home visiting, the workforce, we know that there's turnover that exists constantly. And so this occurred throughout the study. And so we had to continue to train the staff, not only on Craig and his team training them on the study and understanding what it meant to be a part of this, but also them going through the parents as teachers model training and getting that experience. And so it can be hard to be a first or an early career home visitor doing service delivery and learning about this new structure for families participating in a study and having to have families go to a control group. And so that getting that staff buy-in and training was really important for this. And in this study, we were fortunate that 3 of the 4 sites that participated had a centralized intake system that we worked with. So it really tried to help minimize the impact to them, really having interactions with families first, and then knowing that that family was going to be randomized to the control group. So that helped. However, there were some issues and challenges that came up where families were hearing that they were getting referred to the control group, and then they didn't want to refer families to this centralized intake. So it became an opportunity, but also a challenge that continued to persist throughout the study.
Yeah, and I just wanted to go back and emphasize again, like you had mentioned, Allison, that the staff had done this logic model training. And I think that's really important just because we really, I think successfully, because PAT backed this whole effort so immensely, everybody was in on the study, really participating, and that logic model training helped them be part of getting their programs ready for this study, encouraging them that we could do this and we could do it successfully. So that just really made a difference, I think.
Yeah.
Okay, so some of the challenges and solutions in conducting RCTs in community settings. Well, we knew that this was going to be a big challenge, and ended up being a particular challenge. And so one of the things that we were able to do, and Allison, you might want to mention how that, I can't remember, Allison, how this came about, but we turned the tables on ourselves and we said, well, let's do a case study to look at what is it really like from a community perspective to implement this real world implementation of a randomized controlled trial. And so we wanted to study how our home visitors and other stakeholders perceived some of the challenges and some of the issues. And so it was a really unique opportunity. And I think it's a commitment from parents as teachers to really be a learning organization and say, not only are we going to do this randomized controlled trial, but we're also actually going to invest some time and energy into looking at some of the challenges and how this can and can't be navigated very successfully with a real world implementation. And I have to tell you a funny story. In the middle of writing this up, navigating real world implementation of a randomized controlled trial, I get a call from some evaluators from another state who want to evaluate a home visitation program. Their boss had said, we've been dumping a lot of money in this stuff, and there really hasn't been much review of this. There's been no real studies to know whether or not this program is working or not. You guys need to go out and do a study so we can get that evidence. So they contacted the program, and the program people were like, whoa, I don't think so. We're not really that interested. And then interestingly enough, too, they had an on-site program evaluator, and she told them, oh, well, to even do that study would not be ethical. So we can't really do this. When they called us and they're like, how did you even pull this off? And so it's kind of an important, I think, example of trying to understand some of the complications and challenges of implementation at this community level. And just keep in mind that these are researchers, evaluators at the state level who really have no experience in this content area, home visitation. So they would be bringing their own limitations of what would be good measurement, how to do this to the table. And I think this is part of the problem that a lot of home visitation programs like PAT suffer from, is like people might do studies and they might not really have much context and background. They might not contact the national office for any involvement or consultation. But when they publish their results, people really look at them, and it might not be the best designed study for a wide variety of reasons. So that's, again, another, I think, big issue in this whole world of doing research on kind of existing programs, if you will. Okay. And I think we had kind of mentioned this before, but in a lot of ways, home visitation is like the perfect policy discussion about to what extent can you find evidence to support programs and make good decisions with. Because the field started with a study that was implemented early on before the program was ready, and it did not adhere to this program evaluation tenement that people always say, which is evaluate no program until it's proud. An evaluation, a randomized controlled trial that people have confidence in, was conducted on a program that wasn't ready to be evaluated, and they didn't find much. That created a domino effect that was so strong that it still is with us today, where people are still very unsure about whether or not there's good evidence in home visitation. And part of that question, unfortunately, rests on extremely poorly designed studies that use the rigor of research, but not some of the practical, feasible aspects that are important in conducting a study. So,
and to add to
yes,
that, Craig,
please. Yeah.
the randomized controlled trial of parents as teachers in New Zealand. And it was a startup. So they decided to start up the new parents as teachers and also conduct a randomized controlled trial at the same time. And so didn't have an opportunity to think about implementation and really determine. And, so they were learning the program and doing the study at the same time, which didn't bode well for it. So it's just, there's so much thought and consideration that needs to go into these RCTs and lots of ripple effects that it can have when there might not be good outcomes. But it's not that the program's not doing good work. It could be about the design, the timing, and so many other external factors that are hard to account for.
Yeah, I think that's just so critical. I mean, there's so much nuance in trying to understand evidence and judge, for example, whether or not a measure is really a good measure in the first place. But but when they're reviewed, like on the HomeView websites, that level of discourse doesn't take place. it's a box, I think, that's checked. You know, they found an outcome or they didn't. And they don't have enough time to go back like, well, was this a well-measured outcome? And unless you ask that question, then you're really getting you're adding a lot of confusion to what the existing evidence is. And I like to say too, in this field, because I think we have a poor use of language here. A lot of times people say, well, we didn't find any effects on this home visitation program. It wasn't effective. That's not really a very good way of describing it. You didn't find any effects on the measures that you used to evaluate this program. We don't know if you might not find other results if you use different measures, but we don't have that language. And I think not having that language gets us into a lot of trouble. So as part of looking at navigating the RCT study that we did, this case study, we asked parent educators, like, how do you see the benefits of RCTs? And I think this is a testimony to really the work that you did, Allison, and supporting the study, how we work with these sites. They, really saw some of the benefits. There are useful benefits to home visitation program. There are useful benefits to home visitation program being involved in an RCT study. 94% agree or strongly agree. The results improve the program, 90%. The results are trustworthy, 87%. It can lead to program improvements and so forth. So you can see that they're pretty accepting of that. When you get to the bottom, it says when it comes to the impacts of home visiting participants, the benefits of an RCT outweigh the burdens. Well, there it's a little bit stronger, but then we flipped it. And when we asked these types of questions, you can see more concerns came up. RCT home visiting created an excessive burden of data collection. Well, 26% would agree with that. There are better ways to evaluate this, 30%. RCT process makes the parent educator's job harder, 37%. Referral agencies are eager to refer families to programs when they're doing an RCT. Well, now 40% disagree with that. 60% agree. RCTs are unfair to those who are put in the control group. 60% agree, strongly agree. RCT makes it harder to enroll these families in home visitation. That's like a community impact. 77% agree or strongly agree. So you can see that indeed there are some of these ongoing issues, and when we were able to look kind of at the community point of view, more things emerged from our understanding. Now, Allison would be unhappy with me if I didn't share with you some of the outcomes, but we wanted this presentation to focus much more on the collaboration and what we tried to do to make this successful. But having gone through this whole study, we did find some good outcomes that we are happy with. In terms of parenting, we found results on parenting efficacy. I think that's important when you talk to PAT people. The emphasis is on like building the confidence and skills of parents, the knowledge and the skills. And the PAT program was able to create a much stronger sense of efficacy. And I think that's a highly valid measure. And then, like we had mentioned before, we added this sense of hopefulness. Well, now the study also that took place in the midst of a pandemic, the PAT program was able to provide some hopefulness. That seems very profound to me. If you're a therapist or a counselor, building hope is like the essential ingredient of trying to get somebody the help that they need. So I think that's important. In child development, I think really hard to find outcomes. We did find talking and listening and a subscale of understanding on the Vineland showed positive results for the PAT program. It's like a developmental report card. These kids are expressing themselves more, following better directions. You can just see that this is a good outcome. And then reading to the child, that also I think is an important outcome. When I think of reading to the child, my image is a child sitting in the parent's lap and reading, a parent laying next to a child and reading in a bed, that creates a bond, an investment in education. I mean, all sorts of really important things. And let me just say to you too, that as part of what I mentioned, as part of the incentive, both the PAT group and the control group all got books that we gave them when we went to visit them. So in that context, this is an even more important outcome. And then finally, health and safety, we found improved safety practices, and then also really importantly, reduced risk scores. The families that were at the greatest risk showed improvement above and beyond the control group. Okay, so now really we just want to turn to some lessons learned, with doing this. And I'll start us off, Allison, you can jump in, and then I think we're ready to take questions. Some of them are obvious, but hopefully we unpacked how we did this. The importance of communication, meeting with the sites on a regular basis, explaining exactly where the study was at, being honest about every facet of it. That helped them accept the study and make it worthwhile. We had to be flexible and responsive. We had challenges and we had to respond to those challenges. That included changing the randomization schedule, giving bypasses in a limited number, and reassuring the programs that we weren't going to let a family that was in some dire crisis go without a more clear response from our research assistants. Stakeholder engagement, we talked about, and then we've kind of touched about all these implications of policy. I think they're a lot and immense, because for me, this raises a question like, should we continue to demand RCT evidence in this context? I think it's getting harder to do these studies in the community. I think it's getting harder to collect this data, and how much evidence is enough evidence. These are really important and interesting questions. Allison, do you have some things you want to add to lessons learned?
Yeah, I echo everything you said, Craig. And I think from a community organization too, parents as teachers, we wouldn't be where we were without establishing strong communication and partnerships. And I think finding an organization like Dr. LaCroix and his team, LaCroix Milligan Associates, was really essential for us, because we had a common value and vision, I think, for this, and remained flexible. And having that common understanding is so critical when you're going into a partnership with any research organization. So just couldn't say enough good things about Craig and his team and the work that they did for listening, taking the time to plan up front intentionally with the community agencies, and being along the way thoughtful and engaging and listening and hearing concerns, and being able to pivot and make adjustments as needed to really create an opportunity for learning for everyone. Flexibility, many of the things Craig said, flexible, responsive throughout the way. And I think also knowing that there's real world things that happen, like the pandemic and other situations, hurricanes that are happening, that are going to impact service delivery, data collection, and studies. And so how do you just continue to be flexible and responsive in that space, I think is so critical and important in any research learning project. Stakeholder engagement. So I had mentioned that Parents as Teachers National Center funded this upfront. And then along the way, we were able to leverage funding from Arizona's First Thing First and Enterprise Mobility Foundation. And that was essential for us to kind of bridge the gap in funds, and also meant extra ears and people that we needed to engage along the way. And so, funders sometimes want different messages or are interested in different things and want to hear different. And so I think being able to continue to engage not only the local programs, but the funders and folks at the state, and those funding then the programs too, I think was ongoing effort to continue to support the local implementing agencies with key language to share with their funders on maybe why they weren't at capacity for their families that month because they're a part of this study. So that was really critical, I think, in communication and stakeholder engagement really intertwined together. And then no doubt, I think there's implications for policy, and I think a call to action here that that those of you here can spread the word more about this type of study and the ripple effects that randomized controlled trials have on communities. And there's many other types of rigorous research designs out there, and that don't deny families a service that could transform and improve and support them in their lives. And so really, I think our hope is that we can continue to share this message and do more timely, responsive science research designs of how we're integrating into practice and bringing research into practice when we already have a foundation of evidence that exists, rather than continuing to invest in randomized controlled trials. So I think, and that has many equity implications too. Thinking about, home visiting is trying to build trust and support with families and communities, and conducting RCTs and not getting family services certainly can influence and impact that relationship and trust, particularly for families who have negatively been affected by engagement with research historically as well. So really, I think a call to action of how can we influence policy and clearinghouses to not only require randomized controlled trials, but to look at a continuum of evidence that is available.
Thank you, Allison. Okay, so we are happy to take questions and engage in any discussion that people are interested in.
Great, thank you. Thank you, Craig and Allison. I will be your moderator, and I'm going to start with an audience question first that I think actually relates to some of the points you brought up, Allison, but given or depending on the challenges, when is it appropriate to explore other types of study design, a more targeted trial, focus on effectiveness versus efficacy? How might you speak to that?
Well, I think part of what we believe is that there are other options, and that maybe this pressure to do the randomized control trial coming from like HomeV and other entities is unnecessary. It's interesting to note that years ago, this debate came up in the American Evaluation Association, the largest association that attempts to bring program evaluation to help improve programs, wrote a big policy statement that basically said, hey guys, you don't have to do an RCT. There's propensity score matching, there's quasi-experimental designs. There are other designs that can do a good job, a relatively rigorous job of gathering evidence. So I think I think the community needs to open that door to a much wider set of opportunities. Instead, I think people just get locked into this idea, randomized controlled trial, that's a gold standard. That's the one that is going to make the biggest difference.
And I'm going to follow that, Craig.
Sure.
So one of the arguments you made was that that when you all took a look at the weight of the evidence and were concerned about the overall quality of it for a variety of reasons, what stuck out to you as some of the threats about the claim of the efficacy of that? Was it the attrition issues? Was it that the treatment was not identified? And how did that factor in to your decision?
Well, I think when we looked at all of the evidence, I don't know if I'm answering this exactly, so ask the question again if I'm off base here. But the first of all, home visitation is just incredibly difficult to evaluate. And it's a little bit of a black box because people do lots of different things. So that's one issue that always comes up. And I didn't mention this, but I always mention this when I talk about home visitation. It's a strategy for delivering services. And in the prevention realm, that's huge because these parents and participants come to participate. Other prevention programs, they have a really hard time getting people to engage. but not in home visitation. So as a result, what's happened is that people use home visitation in so many different manners. I mean, we even had a previous seminar here on father involvement, but we could have one on increasing breastfeeding. We could have one on reducing domestic violence. We could have, home visitation provides this huge window of opportunity, but that makes it then hard to whittle down and look at the outcomes. And I think people haven't really grappled with that. And in terms of some of the critique of the existing evidence, I mean, it just comes back to a lot of poorly designed studies, implementation problems, and poor measurement that has been problematic. But I'm not sure I answered your question.
I think,
Yeah, and
oh, go ahead, Alice.
I have a follow-up too, Susan. So I think too, with a randomized controlled trial, there's the intent to treat sample. So you have your intervention group, and you have your control group. Your intervention group may not actually get home visiting services, but you have to leave them in the sample because that's how to meet the standards of having a randomized controlled trial, it would change the design if you remove that. What we've seen in past studies is, in one study in particular, 27% of families in the intervention group never got a visit. So, but you're leaving them in, and that is, in a sense, watering down the effects of what really the services are having on families. And so when in a study, we removed that 27% and saw outcomes increase for parents as teachers across many domains. So it's just, I think there's that. I think also in the control group, home visiting is widespread. It may not be as widespread as we want it to be, but it is. And so those in the control group we've seen in other studies can't go get other home visiting services. So it's not like a laboratory setting. We can't control. It's not a clinical trial. It's a real world. And so how can we control and account and really show the true effects? And it's complicated. So there's other designs rather than denying family services that I think are more accessible and reasonable to really in a real world setting on the ground where families have access to other services in their communities.
I'm going to follow that with a related question, which is, can you say a little bit more about the fidelity of the implementation, what you learned, given those challenges that you just mentioned? Yeah, what you learned about the implementation.
Yeah. And we're still going through this data. So the study isn't completely done and we haven't finally finalized all of that. But Parents as Teachers model has certain fidelity requirements like dosage of visits and, frequency and screenings and when they should be conducted and resource connections. And so we measure and track that annually. Now, what we haven't had the chance to do yet is look at how that implementation influenced outcomes. And so that is one of the next steps that we're going to explore together. There's lots of data to mine. And also we have the potential to look at, like during the pandemic, virtual services, what were the effects for families that got virtual services versus on ground. And so I think there's lots of opportunities for us to continue to learn from this data set in the long term.
Thank you. So besides having some of the autonomy with the funding, as you mentioned, Allison, aside from this, what I think is a really beautiful example where you and Craig were in this for a long haul, that you let there be quite a time of trust building and ramp up, which I think is exemplary and can be really hard, to spend a year of planning. So, but also is, I just wanted to applaud you for both of you for those efforts. What were some of the other enablers other enablers for this program that really facilitated the RCT?
I think that's more for you, Allison.
Yeah, it's a great question. Certainly, I think, the stakeholder engagement process along the way, continuing, not only during that planning phase, but throughout. And then as we leveraged additional funders, keeping them engaged and supporting the local agencies and talking with their funders so that they could continue to get the dollars. I think too, one of the things along the way is sharing the data as we had like preliminary results or baseline like equivalents back with the local implementing agencies. I think the sharing that back with them just to help them learn about where we were in the project helped continue to keep them bought in and engaged in the project long term. I think by us creating some monetary incentives for them participating, waiving affiliation fees that they would pay was something that I think was important. We did a visit to and did a big luncheon celebration. We went to Arizona and met the sites and had them all join like a big celebration after recruitment of families ended, and just we got a chance to listen, I think, and hear about some of the challenges and struggles along the way. I think the strong design of the study that Craig and his team put in really helped enable it to be successful in that thoughtful and just, providing the clear channels of communication so that folks could share as they were having concerns and some ethical concerns. And we did as well. And so we would sometimes, share that we did and how can we together work through this to make the most of this, since we need to have the study done to continue to get funding for the local communities.
Here's a funny funding story. I'm sure you remember this, Allison, but Allison and her team came to Arizona and brought some of their board members, and we brought stakeholders together and over dinner and a discussion. One of the Arizona people that represents First Things First got more interested in the study, and the board member was able to essentially get them at that point to commit more dollars to the study. Communicating and getting people's engagement at that level actually paid off.
Thank you. Many of your efforts that you've described have been getting a lot of buy-in at the practitioner or program level. What about, did you learn anything from the participants themselves about, or to what extent was their voice directly elicited or gaining buy-in from potential home visiting recipients?
Certainly, as a part of the program, that each year the local organizations ask for family feedback and engage that in their ongoing services. That's a part of bringing family voice to the table. And the visits with families are actually co-designed. So the families share topics that they're interested in, and the home visitor brings that in. So I think that that's kind of more from the program perspective, the voices that were certainly coming in. In the study of looking at the ripple effects, there was a few control families that were asked about their experience, and they shared that they enjoyed having the data collectors come in and ask reflective questions, and it gave them a chance to consider and think about how are they supporting their child and their parenting behaviors. So I think that there was some connection there between the research team and the control families, and some reflection that gives parents a chance to even consider their own work and what they're doing to support their children. So while I know that didn't necessarily influence the study per se, I think it was happening, kind of on the ground.
Well, yeah, I like that point, Allison. I think that it's an important methodological point. It's hard. I think it's increasingly hard to differentiate the treatment from the control group. And the control group did get visited consistently by the research assistants, and we had zero turnover. And that's not true for the program sites. So they were seeing the same person consistently and talking, and that person was talking to them about their child. In home visitation, if you ask people what's the most important thing, they always say the same thing. It's the relationship. Well, we had a very good relationship with our control families. And I also always tell this story. I was in one of our data collectors' office one day, and the phone rang. She answered it. It was a mother from the control group. that wanted to talk to her. So it's not as if the control group is not getting anything. And that's good, but it's desirable from a research point of view.
Well, that's perfect segue into the next question, Craig. How are you coping for some of this variability among the different sites, the potentially differential attrition, what control families may or may not have access to? Yeah, take it away. How are you grappling with those known sources of variability?
Well, I think we're going to explore all of those different aspects. We did not have differential attrition between the treatment and the control group. I think it was a 3% or 2% difference between those two groups. So even though the attrition did occur for both of the two groups, they stayed relatively even. Always testing for the baseline differences. The randomization worked. The baseline differences, equivalency stayed consistent throughout the different groups. And then other than that, because the sample size is decent, but it's not huge. At this point, we limited our analysis to the fundamental questions. We did a little bit of exploration, but not too much. In our first paper, it's mainly the main results of the studies. But when we looked a little bit closer, for example, we pulled out a subsample of our families that are Latino, and we found more outcomes for the Latino families when they were all grouped together. So we have more work to do to look at some of those different aspects. But we were really trying to ask the bigger question on how effective was the Parents as Teachers program when we looked at across the treatment and the control group.
Okay, here's a measurement. Craig, you said you're a measurement person. I'm going to try to lump some of the measurement questions together.
Okay.
Did you do you have some other emerging triangulated data sources that have emerged over time that build confidence in what you've measured? Have you done any review of, are the outcome measures that you indicated as being, that you think are really crucial? How have they been performing? Have you had to make any modifications to those, and how?
Sure. So like most home visitation programs, which is, again, one of the complications is that, typically you have a lot of measures because you're trying to capture a tremendous number of things. So there is some effort to look at how some of the different measures relate. An example would be, we looked at parenting efficacy, but we also had included a measure of hope. And those two things kind of go together and kind of reinforce, I think, the conclusion that we were able to boost these families' confidence in a way that made a difference. So there's some of that. We didn't do that in this study, but in a past study, I triangulated some data in an interesting way. We had asked the parents to describe their children, and then I used linguistic software, and I was able to show that the families in the home visitation group used words in a completely different way when describing their parenting and describing their child than they did, than the control group did. I thought that was a pretty unique way of trying to really look in a really different manner of the outcomes that you might be able to find. And previous work on this has shown that the words people use make a difference. You can discriminate depressed from non-depressed people based on the words that they use. So the fact that the program helps people use different words seems to be meaningful and interesting. I think, when we tried to select these measures, we looked very carefully at their at the face validity, because I think that's the most missing component of studies. And we pre-tested them and asked parents to comment on them, because we really wanted to try to ensure that those types of measures could capture what the program might be able to affect. And that was helpful to us as well. I think in every home visitation study is a new opportunity to test out different measures. I think one of the things that we keep learning is that direct measures usually show the strongest outcomes, like measures of safety. The more direct, the better. I like to think of measurement as a set of concentric circles. You measure the most direct thing in the center the most, and then you kind of test the boundaries of the intervention by going further out. But I think too many people fail to find the most direct measure of the outcome. And that's a really good place to start, because we need to do a better job of documenting the potential outcomes of these programs. So that's some additional comments on measurement.
Allison, let me ask you this. What have you, given that the study is still ongoing, have you changed any policy, programming, or practice based on this, that you've implemented before the study's fully wrapped up?
Yeah.
And what was it?
Yeah, that's a great question. I think, one of the things that we were piloting prior to the COVID-19 pandemic was a virtual home visiting pilot with the University of Southern California. And that work was kind of completed, and we were seeing it is feasible, parents like it. And then the pandemic happened. We were looking at trying to integrate more hybrid approaches versus full virtual, because that was kind of what was coming up from families' perspective. So what's happened is, I think hybrid services are sometimes the norm. Now, on ground is the majority of visits, but when a family might be sick, or might be moving locations, might be out of town, or there's a natural disaster and there's a place to connect with them, I think that their virtual visits are like supplemental and still happening. And so that is a practice, I think, that is now happening, and started kind of in the middle of early on, actually, in this study. And so in a way, I believe that this study reflects hybrid home visiting rather than the kind of before on ground only home visiting. As we get into more of the implementation findings, I think it'll be interesting to see if there's other practices we change. But that's kind of been, I think, the main change.
And audience, I'm chaining some of your questions together. I'm going to follow this, Allison. What is the next step or next finding you're most excited about knowing about?
Yeah. I was so excited with the HOPE findings. I think it validates the listening to the home visitors on their perspective of outcomes, and then finding a measure. And as Craig said, I think then triangulating that with parenting efficacy. So I'm very excited about that. I also think Craig and I have had some conversations that some of the safety measures, there was outcomes, but I think there could have been more. And so is that a place for us to lean in a quality improvement way, to thinking more about how are we really supporting some of those safety features, and taking a look at some of the measures and thinking about what is happening in the home and thinking more critically in that. So I think that's a quality improvement space for us in the future.
Thank you. Craig, your perspective, what are you burning to dig into?
Yeah, I would be curious, obviously, about a lot of different things, but it would be fun to see how much we can increase the impact by looking at different things. Like we did do an intent to treat, but we need to go back, and can we show that we can get bigger outcomes for participants that are more engaged in the program? That would be important. We want to look at some of the differential outcomes. I'm excited about that as well, by trying to figure out for whom this might be most effective. And I think just to emphasize this point again, I think Allison did a great job of presenting this, but just from a methodological point of view, and a lot of people might disagree with me here, but I really don't think that an intent to treat methodology makes sense in a prevention study, Prevention is very different than intervention, where intervention are people coming to the intervention to get help. Prevention, you're reaching out to people to engage them in the process. So you're going to have a lot more attrition. You're going to have those things that then affect the ability of the study to show its outcomes. So I'm hoping to spend a little bit more time thinking about that issue, because I just don't think that we've addressed that as thoroughly as we can. I also got really, like, we did not in this in the 6-month follow-up, we did not find differential results on resources. I think we need to go back and look at how we measure and capture resources more effectively. And I think from an implementation point, and Allison, you might have a different idea about this. Are the home parent educators, are they able to bring all of the kinds of resources that truly exist in the community? You know, as a social worker, we know that resources are so critical. And also, it's kind of a specialized skill, and it might be a skill that can really make a difference. Home visitation has always claimed that it takes place in a community of support and resources, and that those are necessary, especially because they're trying to impact some of the more difficult problems that families face. So I really would like to think more about resources and how those can impact program outcomes.
Yeah, agree with that, and would also like to add too that this study looked at children enrolling in a continuum as parents as teachers does. So a family can enroll prenatal, they can enroll anytime up to age 5, and you can stay in the program up to 5 when you age out. The prior studies have really narrowed the enrollment criteria and only looked at prenatal children or children under the age of 1. And we were really trying to reflect, again, the practice, like what happens in practice. Families are enrolling at a time where they feel it's critical or are interested in that program. So that this study reflects that. And in a way, I think there's an opportunity to look at the different ages of children at enrollment and the times and what might be some differences we might observe in that space as well.
Wonderful. We have 3 minutes left. I'm going to ask one more question. Thank you, audience. I hope I haven't distorted your questions and trying to get through as many as possible. But Allison, from your perspective, what would be would you do this again? And what would your advice be to someone in your position biting off this kind of collaboration?
Would I collaborate with Craig and his team again? Absolutely. We are and continue to in many spaces. I think the randomized control trial, that is really going to be up to policy, and how can we try to influence policy so that models that have already established an evidence base don't have to continue to do randomized control trials. I think that's my hope, so that we can use more real world, other rigorous designs that don't really restrict services for families. So that would be, I think, my hope, that we can employ other study designs, but absolutely we continue an amazing partnership with Craig and his team on several other projects as well.
Okay, 1 minute, Craig.
Yeah, okay, quickly.
Your advice to a researcher in your shoes.
Oh, okay, a different question. Okay.
Okay, sorry about that.
Yeah.
Or you could answer the other.
Okay. Well, I think I want to say a few things about just building on what Allison said. I personally think, like, the the policy, too powerful. It's having too much policy impact. People don't understand the limitations enough. And nobody's critiquing that enough. I mean, I really think we need more critique of that. Instead, everybody just trusts that the conclusions are valid and that they've reviewed these studies effectively. Given the difficulty and nuance in research and the limitations, 30 years of research, it takes a lot to understand a study and what it really can and can't contribute. In terms of doing it, again, it's like a necessary evil. So we'll keep doing it because that's where the policy is. But I really hope to move the policy needle in a different direction. For researchers, collaboration, understanding the community and its context, and obviously reviewing measures, designing a study that you really have confidence in. It takes a lot of upfront work. You can't just grab a measure that seems reliable and valid. You got to figure out if that measure really makes sense and is going to capture the program outcomes that those home visitors work so hard to achieve.
Thank you both. Thank you, audience members, for your thoughtful questions. And what a lovely presentation about what sounds like just a wonderful partnership. Thank you very much.
Yeah, thank you. We enjoyed it.
For having me. Thank you.
Thank you all for the great discussion today. We're gonna put up a slide now that has a link to where you can go and get the recording for this great talk, and then also where you can register for the other remaining webinar in our webinar series. So we'll also share those links in the chat, but thank you all for being here, and thanks again to our presenters.
Thank you.
Thank you. Bye.